So John Modern is our director of photography, and he was doing an interview with a healthcare executive, and he asked the question, why are you taking your clinicians and putting them through the meat grinder and spitting them out, demoralized, traumatized, burned out? What would you say to them? And you can't make this stuff up. The administrator said, I would tell them to suck it up, Buttercup. Having, gone through college, gone through medical school, gone through residency, devoted 11 years of my life to a very demanding job, I'm resilient. I know how to work hard. I know how to push through obstacles. Telling me to suck it up, Buttercup, is complete, frankly, BS.
Hello and welcome. I'm Chris Malone, and I'll be your host for today's discussion. Thanks very much for joining us. Before we begin, I'd like to welcome Carla Cardoza, a patient experience consultant at PRC. PRC is our partner in this program and also partners with healthcare organizations nationwide to improve the healthcare experiences for patients, physicians, and employees by helping leaders turn insight into meaningful improvements in care, culture, and outcomes. Welcome, Carla. What can you tell us about our guest today?
Hi, Chris. Thank you. Dr. Otten is a board-certified family physician, physician advocate, author, and healthcare reform leader dedicated to restoring humanity in medicine. Over a career spanning more than 2 decades, he has served in numerous clinical and leadership roles, including as an accountable care organization medical director and as a decorated naval flight surgeon, receiving the Atlantic Fleet's Naval Flight Surgeon of the Year award in 2006. He currently serves as lead catalyst and board chair of Medicine Forward, director of strategic relationships for emergency care specialists, and is affiliated with the direct primary care organization, Plum Health. Dr. Otten's personal experience with physician burnout in 2019 transformed his professional mission. Since then, he's become a prominent advocate for clinician well-being, healthcare reform, and rebuilding trust in medicine. He is co-author of the book Ripple of Change, which explores how individual actions can catalyze broader transformation in healthcare, and serves as executive producer of the documentary Suck It Up, Buttercup: Trust and Betrayal, Healthcare in America. This is an investigative film that examines the systemic pressures affecting clinicians, patients, and families, and seeks to inspire a movement toward a more humane and sustainable healthcare system. We are pleased to welcome Dr. Otten in Humanizing Healthcare.
Oh, thanks for having me. What a kind introduction. Every time I hear something like this, I think, are they talking about me? But it probably explains why I've got more gray hairs than the picture in the promo.
Well, I'm wondering how you managed to do all of those different roles at once. Wow, that's an impressive list of current activities. So welcome to the program, Todd.
Thanks. Yeah, thanks again, Chris, for having me.
So we would love to hear the story of how you chose a career in medicine. Was there a particular experience or influence that led you to choose that path?
Yeah, I think it's probably a multifactorial answer to that question, like many things in medicine, I suppose. I was that bright kid that the teachers probably didn't always know what to do with, who would walk up to the chalkboard and just write the answer down, and then I would get questioned, well, where's your work? And I would chime back, is the answer wrong? And that often led to some issues. But I think, ultimately I did Parks and Rec for a while, and I was the supervisor for a couple other teenagers, and we took, about 80 kids were there. So we play games with them and teach them things and play sports and do crafts and activities. And that's where I really learned to love and crave that human connection. And thinking back on it, though, I think some of it going into medicine was a bit of a trauma response too. That young child who felt like they were never good enough, so what do you choose? You choose one of the hardest careers you can. And so I think that played a little bit of a role as well.
Wow. Well, we're glad you did. You're making a huge difference for all of us that work in healthcare. Now, in the past, you've spoken openly about your experience with physician burnout in 2019. I'm wondering if you could tell us a little bit of the story, what happened during that period, and how it changed your view of medicine and your career.
100%. So, and forgive me, sometimes when I get on these things, I get a little bit of emotional talking about some of the things that are drivers for me. And just got asked to sign a death certificate prior to this, which always brings up a lot of emotions, for those that have ever had to do that.
Of course.
But in terms of my experience through burnout, in retrospect, Chris, it was obvious. Like I was doing way too much. Like I was seeing 6,000 visits a year. I was ACO medical director. I was chief of staff. And, the lack of compassion, the frustrations, the anger, the feeling like you're not good enough, all those things were obvious in retrospect. And then there was a tipping point when I had some pay withheld because I had two charts that were incomplete. I mean, like
Wow.
that is completely insane that even occurred. But it had evolved from, I love seeing patients, always have loved seeing patients. It is a joy that is almost hard to describe the euphoria, the dopamine hits of helping other human beings. I went from that to being in my backyard in tears on a regular basis, hating my job, absolutely hating it for many factors that I had absolutely no control over. And so that experience, fortunately, I got some time off and I was able to come back and all these other things. But that experience is ubiquitous right now, and not just for physicians, but for nurses, other clinicians, and it's affecting all of us. It's affecting patient care. It's affecting cost, and it's definitely one of my big drivers to why I want to see massive systemic change.
Well, your experience, as you've mentioned, is so, common, but not everyone has taken the initiative to write and speak and try to lead organizations and change about it. Thinking about your book, Ripple of Change, which I have been reading very avidly, the title suggests that even small actions can have profound consequences. Was there a particular ripple in your life that kind of made a difference? And, what are the ripples that you're hoping to create with your new documentary film?
Yeah, for sure. Without playing too much of a spoiler with the book, I suppose there was a key moment that led from I talk about sort of career 1.0, where it was predominantly patient facing forward and leadership roles to a combination of that and then these advocacy things. So I had gone through burnout. It was a few years after that, and I had been very transparent with my administration that maybe I wanted to, go part-time a little bit. I wanted to work on succession planning. We had an office that was just incredible. In the book, I dubbed that chapter The Office Utopia. So it is possible to have those things if you have the right leadership and the skill set and the right players, right? So I walked into this meeting, ironically, with a coffee cup that said, "Be careful or you will end up in my novel." And I set it on the desk in front of me. I'm not making this up. And the VP's like, "Is that a warning?" And I said, "Well, I guess it depends on how this meeting goes." Ultimately, there was a decision that was made to save money on rent, and they were going to move me back to the town where I'd gotten burned out in a matter of months. I resigned the next morning.
Wow.
I had been there almost 13 years at that point, and they had crossed the line in the sand. And I was in a position to stand up for myself. I felt like I was standing up for my colleagues, some who are no longer here, and I felt like I was standing up for patients. And that moment was a huge ripple in my life and has taken me on this incredible journey of finishing the book and doing advocacy work and now working on, the documentary, which they're intertwined, so the book is, my journey and one of my patients' journey. The film is intended to be really pulling the curtain back for everybody to see what's going on behind the scenes in the healthcare delivery system in the United States and how greed has negatively impacted it. So yeah, and I guess, what we hope to accomplish with this is I don't have the one correct answer for this mess that exists. I'm not sure anybody has the one correct answer. But I think if we continue talking about things, continue to collaborate, to be curious, lean into those traumas, I think the answers or the solutions will start to come about. And that's really what we're trying to accomplish with the film, is to educate, empower, and ultimately activate the masses is the goal.
Yeah. Well, I think simply sharing your story can be a ripple in and of itself. It helps convey what's happening in a way that's more than facts or figures or statistics or what have you. Now, the title of your documentary, Suck It Up, Buttercup, is certainly a provocative title. I'm wondering, how did you and your collaborators settle on that, and what exactly are you intending to convey with it?
Yeah, so Suck It Up Buttercup, the origin story of that, and actually there's a little bit of a YouTube link that I think got pushed out. So John Modern is our director of photography, and he was doing an off-the-cuff, quote unquote, interview with a healthcare executive. And he asked the question, why are you taking your clinicians and putting them through the quote unquote meat grinder and spitting them out demoralized, traumatized, burned out? What would you say to them? And you can't make this stuff up. The administrator said, I would tell them to suck it up, Buttercup. Having, gone through college, gone through medical school, gone through residency, devoted 11 years of my life to a very demanding job, I'm resilient. I know how to work hard. I know how to push through obstacles. Telling me to suck it up, Buttercup, is complete, frankly, BS. Like, more resiliency isn't the answer at this point. We have systemic changes that are crushing, or systemic issues rather, that are crushing people. What's interesting about the title, Chris, is when we first, the creatives, the three creatives to the core group were like, oh, this is the title, and the two physicians were like, I don't know if that should be the title.
Right.
I think I came around relatively early on with the title, and Marianne Wilbur maybe took a little bit longer. But ultimately, if you think about it, we're all sucking it up. Whether it's access, whether it's costs, whether it's, bankruptcy, bad outcomes. I mean, the American healthcare people at large are being told to suck it up by our healthcare system. And so I think there's a lot of layers to the title in and of itself.
Yeah. Well, yeah, I think that is the kind of sentiment that could be expressed only by someone who had never experienced firsthand the kind of moral injury and dilemma and sadness that a clinician does when they lose a patient, that they've had a relationship with for a long time, or they see things happening that they know are just not right. And so it really speaks to the disconnect between the experience that clinicians and patients have versus those who are perhaps making, authorization decisions or reimbursement decisions and things of that nature.
Yeah, 100%. I mean, ultimately, the big part of the theme of the film is greed, and how
Mhm.
greed has had such a negative impact on how we deliver healthcare in this country. And you can see it top to bottom. It's not like there's one problem. There are just layers and layers and layers of issues. But that's part of the reason why the call to action of the film, we really wanted to make it evergreen. So we
Mhm.
wanted to make this applicable next year, hopefully 5 years from now, hopefully 10 years from now, by encouraging people to unlearn learned helplessness, which I can explain,
Yeah.
but also accelerating an impact network that values people over profits. That idea of this web of entities and organizations and individuals who are collaborating and talking and working together towards solutions. So that's how we came up with the two calls to action.
You mentioned, learned helplessness in medicine. Tell us a little bit more about what that means and how does it prevent both clinicians and organizations from pursuing change?
Yeah, so learned helplessness is that notion that regardless of your efforts, you can't change the outcome. It goes back to a study in the 1960s, and I don't want to butcher the two individuals' names who did it, but they put dogs in a cage and they shocked them. And they shocked them. Initially the dogs were trying to escape. After a while, they just gave up. Even when the door to the cage was opened and they were continuing to be shocked, they would just lay there. And that's what's happening to a lot of our colleagues related to barriers to providing care, whether it's prior authorizations or fiscal barriers or access or whatever. People are just beaten down to the point where they feel like their efforts don't even matter anymore. I heard the term zombie doctor recently from one of my colleagues, that notion of that physician that is literally just there, a shell of themselves, just trying to survive the day. And you think about that, right? Like, how does the patient in front of them feel when they're not getting the best out of that clinician, right? It's a huge problem. And we've gotta realize, like, our words matter. Our actions matter. What we do, how we treat one another matters. And if we all start to do that just a little bit day by day, we can start to see this turn around.
Yeah. Now, you and your colleagues argue that burnout is not an individual resilience problem, it's a systems problem, and that there are systemic failures driving burnout, moral injury, and disengagement, and all of that. What are some of those systemic failures and systems that really need to be changed in your view?
Oh, yeah. To me, burnout is a symptom of a dysfunctional healthcare delivery system, right? As I mentioned before, physicians are resilient at large. And I speak to this as from the physician perspective because that's what I do. There are so many things that impact our ability to care for people. And I mentioned a few, whether it's prior authorizations, access, et cetera. But I'll give an example of how this plays out. So we're all familiar, probably to one degree or another, with electronic medical records, right? So when I went through burnout, I was like, I'm going to do a little bit of a thought experiment. I said, okay, how many days a week do I work? How many weeks a year? How many patients are seeing? What's the average number of clicks per day? All these other things. So I calculated how many clicks into my career I was when I experienced burnout. And the number was roughly 18 million. So, and I double checked it. I triple checked it. I looked through the numbers. I mean, why are we having some of our highest educated people entering things to the tune of 18 million clicks? That's just one contributor to burnout. The list goes on and on and on.
To me, what I found remarkable about electronic health records is that the notion that humans would have to enter manually so much information seems like that should have been identifiable as a system issue before it got started. And I can understand the desire to document things and so forth, but it seems like that should have been a problem that was foreseeable. The time and effort demands that would be required for clinicians to manage and enter all of that. Now, arguably, we've been told that some of that is going to be taken on by AI scribes and things like that, but that also has other challenges that come with it. What's your thoughts on AI scribes? Is that going to, in your view, change things much or just introduce other challenges?
Well, potentially both. So I've actually had the experience, the beginning of my career was paper charting, handwritten notes that no one can read and all these other things, right? To my first full-time job where there was a chart that was this thick and there were two sections. One was progress notes and one was everything else, which was completely ridiculous trying to find something. To, with where I'm at now with Plum Health, which is a direct primary care organization, we do have Ambient AI scribes, and there is definitely some benefit to that. Over time, I got pretty good at being able to do data entry and still keep my head up and talk to the patient. But when you can just turn on a button and it records everything, and you get familiar with saying, hey, here's a physical exam finding, and you just spit it out and the computer catches it, it's kind of nice. But if it's being utilized to create more productivity, more RVUs, do more, then it's a problem. Because pajama time has been around for a long time, where clinicians are spending 2 to 4 hours of time at home charting. Ambient AI scribe should not be utilized to increase productivity. That's me getting on a soapbox. So I'll now get off the soapbox.
No, but I think you touched on an important issue. Is arguably part of the benefit of Ambient AI scribes is that it allows patients and clinicians to spend more time connecting and less time documenting. And, you've talked about in the documentary financial pressures, consolidation, bureaucracy, and all of that. If AI isn't going to help strengthen those relationships, what are you seeing is happening to relationships from all those other pressures?
Oh, related. Oh, wow. So one of the things, Chris, I would say I say it every day almost, is I see the physician-patient relationship as a team game. Okay, that relationship is so important to making a difference for that individual, right? Like, so if I say, hey, I want you to do this, that, and the other thing, and they're not hearing anything I'm saying, and they walk out the door and do the exact opposite, what have we accomplished? Nothing, right? So there needs to be that trust. There needs to be that rapport. And all these external forces that have come into play have eroded that trust in a dramatic way. And you hear it constantly from patients. I had a suboptimal visit with this person or this specialist or what have you. We have to unwind that. Part of that is time. And if technology can afford us that time, that can make a huge difference. But I think there's other things that are coming into play that are positive examples. I talked about Plum Health, which is a direct primary care organization that I work for. My appointments, Chris, are 30 minutes or an hour.
That's great.
I see about 10 patients a day. So, half the time we're done with the visit and we've got 30 minutes left and we can talk about whatever we want. It's amazing. The other group that I work for is emergency care specialists, which is where I'm at currently. And they totally think outside of the box. They've got an amazing clinic where they're delivering emergency care outside of the four walls of the ED. These are the kinds of things that we need to continue to explore and offer to patients to improve access so people are getting, pun intended, the right care at the right time, if you will.
For those who may not be familiar, perhaps most are, but just in case, could you spend a moment explaining what direct primary care means and how it's different from perhaps health system or other types of primary care delivery programs?
Yeah, for sure. So basically, direct primary care is really a subscription-based model. So for example, average price is $75 to $100 a month. And for that $75 to $100 a month, you get pretty amazing access to your clinician, whether it's through same-day appointments or next-day appointments or messaging through the app. At Plum Health, we offer labs at cost, essentially. Same with many prescription drugs. And so your total cost of care goes way down. And the reason for that is you've removed the 15 to 20 people that currently exist in the fee-for-service world between the clinician and the patient. Like when I'm done, I'm not having to fill out a bunch of billing codes and check this box and do all these other things. Patient comes in, we talk about their issues, maybe we get some blood work, maybe we fill a prescription, set a follow-up, and that's it. There's no explanation of benefits that comes flying in the mail 3 months later with a huge bill that they're not ready for and all those other kinds of things. So it's really streamlining the process and really, in my opinion, kind of a massive step in the right direction, like getting those relationships back to where they should be, rebuilding that trust. Yeah. Hopefully that helps.
And I gather that not only is it a really good experience and model for patients, but it sounds like it would have a lot of benefits for clinicians as well, in terms of the standpoint of preventing burnout and supporting their well-being and so forth.
100%. It is a joy to be at work. To go from a panel at my peak of probably 3,000 patients to a panel of 500, I get to know people. There's times where I'm caught up for whatever part of the day. And I'm like, I wonder how so-and-so is doing. So I just call them and check on them and say, hey, did you get this test done? Or did you get that test done? Or for a great example, yesterday, a lady called in. She was concerned she had a UTI, and the MA's like, hey, I don't see any openings today. And I'm like, just forward me the phone call and I'll do it right now. And I was like, Dr. Otten, Plum Health. And she's like, wait, what? We're doing this now? And I'm like, yep, let's talk right now. And that's a joy to be able to know that you kept somebody out of probably an urgent care, maybe an ER visit for a few minutes of time.
Yeah. One of the things that film touches on pretty strongly that I'd like to get your thoughts on is this notion of physician suicide and the rate of suicide among physicians versus the general adult population, and the toll that, it takes on not only those who, unfortunately take their own lives, but those around them that knew them, worked with them, and lose them. Tell me a little bit about, the issue of mental health among clinicians, and is that a topic that we are not perhaps talking about as much as we should?
Lots to unpack there, Chris, for sure. To start, it is definitely a topic that we're not talking about as much as we should. Having trained roughly 25 years ago, which dates me a little bit, I was taught to stuff everything in a box and compartmentalize, and I became an absolute expert at doing that to the point where I never processed a lot of things. Physician suicide is a major problem right now. We lose about a physician a day in this country to suicide, and there's only 1 million of us. The rates are higher than the average. It's worse for women. In my career, I've lost 4 of my colleagues, and I thought I might make it through this without crying, but forgive me if I do. But 2 of them were really close to me, a friend from medical school, and then one of my mentors. And when my mentor took his life, I went to work the next day and saw patients. That's insane. That is completely insane. And I never processed that moment for 7 years. I mean, in fact, the footage in the documentary came out of an inspiration in talking with his son. I was like, I need to go visit his grave. And the footage in the film was the first time I ever went there. I'm not gonna lie, I couldn't stay long. It was a tough moment. But it just speaks to like we shove this stuff aside and we expect clinicians to be superhuman. We're human beings. We have feelings and emotions and families and loved ones and fears and prior traumas and all these other things. We have to think differently about mental health for clinicians, not stigmatize it, and get people the help they need so we can stop this crisis that's going on.
I mean, dealing with life and death issues every day, if you think about in the loss of a loved one in a family that might happen prematurely or suddenly or something like that, and the trauma that causes in a family. Now imagine the care providers that have to deal with that every day, sometimes even with their own colleagues. And it's just like a PTSD type, scenario, it sounds like.
Over the course of your career, if you see enough patients, obviously people are going to pass, right?
Yeah.
I had one of my coping skills was I used to write the names on a sheet of paper of people that have passed. And most of them were expected. They had cancer, they had heart disease or whatever. A handful were unexpected. But imagine a list of 40 names, another list of 40, another list of 40, two-sided, 7 sheets of paper.
Yeah.
That's a lot of people that you knew and cared for, and it's tough. It's a tough job, without a doubt.
Yeah. Now, on a brighter note, are there any organizations or leaders that you encountered during the making of the documentary who you think are getting it right? And if so, are there any lessons, that we can learn from some of their example?
I mentioned a couple of them, and I'll mention a few more. Emergency care specialists is one of the groups that I work for, and I think they're physician-led. They really embody the quadruple aim. They really do things the right way. They have an amazing culture to the point where I consider them a unicorn of ED physician groups, which is part of the reason why I work for them. So they're one, Plumhouse another, but that could be extrapolated to most DPCs. It's just an amazing opportunity for those who are clinicians who are thinking about walking away to try something different, right? But there's a couple other organizations that we highlighted in the film. One is Orchid Health, and part of their ethos is well-being first. That says it all right there, not just clinician well-being, but patient well-being. And then there was another organization, I think they're down in Florida, Memorial Health, that was discussed in the film, that really talked about not using financial drivers to make decisions, but clinical drivers to make decisions. And the financial people were entrusted to figure it out and make that happen. So you weren't getting worse nursing patient staffing ratios and things of that nature. And this is just like the tip of the iceberg. There's a ton of amazing organizations that are out there. I think one of the issues, Chris, though, we've got to work on is a lot of these efforts are even siloed in and of themselves. And we've got to undo that a little bit.
Yeah. Now, we talked a lot about the film. It's not in broad release yet, but you're working your way there. Can you tell us a little bit about how listeners could view Suck It Up, Buttercup while it's in this pre-release stage?
Yeah, so I'll give you the cheat code. So as a family physician, when you start making a documentary film, there's a lot of things that you aren't aware of and don't know in terms of what should the budget be. So there is still some capital need for mass distribution. And part of the way we were trying to navigate that particular issue is anybody who makes even the smallest of contributions to our GoFundMe will get a link to watch the film. That hasn't been widely publicized, but if you want to watch it now, that's the way to do it.
Yeah, and so we'll provide in either the chat or in the follow-up email a link to that GoFundMe campaign. I did make a contribution. I was able to watch it on YouTube. It's very compelling. It's kind of PG-13 rated. I would say some of the language is kind of emotionally, charged in that regard, but I think it's, because of the passion that you all have behind it. So thank you for sharing that. Oh,
for sure. For sure. Yeah, there's a couple of prominent people that possibly drop some F-bombs in it.
Yeah, that's right. Mark Cuban is in it. Don Berwick, Dr. Don Berwick is in it, and many others. Now let's pause and take a few questions from listeners. We have one here from Dan Pomerantz. And he says, please make sure that everyone knows about the Emotional PPE project. They provide a free short-term therapy for any clinician who needs it, and that is available at emotionalppe.org. Are you familiar with that one, Todd?
I think I actually know Dan, full transparency, and I think he's shared this with me. I'm not sure I had a chance to dig into it completely, but Dan is an amazing individual. And so even just the concept of emotional PPE makes a ton of sense to me. So anything Dan's talking about is worth checking out, in my opinion.
Good. Here's another question from Lisa Cardino. Can you please talk more about the model for an impact network? What are you implementing and seeing from that?
Oh, another friend of mine. So this is kind of nice to hear some of these names. So there are several entities out there working towards this. Okay. And maybe the simplest way to visually describe this is a bit of a spider web, where you've got these different nodes that are connected in this perhaps seemingly chaotic picture, if you will. There's an organization called the Healthcare Reinvention Collaborative, which is specifically working on trying to accelerate an impact network. And the idea behind an impact network is that you're getting people, orgs, et cetera, from different areas, expertise, sharing, talking, collaborating, working together towards solutions, which is really the opposite of a lot of the siloing that exists, not only in healthcare delivery, but also in those trying to make change. So I would definitely check out the Healthcare Reinvention Collaborative.
And is that the one led by Denise Wiseman?
It might be, yes, indeed.
All right, good. I thought so. Another question, if every healthcare leader, clinician, and patient listening today committed to creating one ripple of change tomorrow, what would you encourage them to do first?
I always have to take a deep breath before I answer this one, because you can take it in a lot of directions. But I often come back to, if you're concerned about a colleague, ask them how they're doing. I regret to this day not asking my mentor how he was doing. So please, if you're worried about somebody, just ask them, hey, are you doing okay? And that might open the floodgates to seeing somebody who truly needs help. And maybe you're the gateway to getting them help. So sorry I got emotional.
No, it's totally understandable. And thank you for sharing such something is so personal with us. It amplifies the ripple. Now, as listeners know, we always like to close each episode with this last question. And that is, do you have a favorite quote you can share? And if so, why is your favorite quote?
I've really learned to gravitate toward or land on the one from Maya Angelou. And I wrote it down so I wouldn't screw it up. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I think for me, it's allowed me to be myself. It's allowed me to feel like it's okay to cry in front of the camera. I've learned that people like hearing stories. People don't just want to hear a bunch of stats and quotes and statistics all the time. And I'm not that guy, and so I've embraced that. I've embraced that it's okay to be not okay. It's okay to be authentic. And it's okay to tell some tough stories that people hopefully will learn from and create their own, to coin a phrase, ripple of change.
Absolutely. That's one of my favorites as well. And I think it really puts your finger on, some of what I think is missing in healthcare, especially in the United States. And that is when we think about it from a quality measurement standpoint or a process or care delivery standpoint or what have you, so much of it is broken down into, did we say this or did we do this? Without much attention to how did we make you feel? Because that's that how did we make you feel part that is going to determine whether a relationship forms, whether engagement will continue, whether medication will be adhered to, and whether there will be a patient there to receive the care they need when the time is most critical. And so I really appreciate you drawing attention to that.
Absolutely. Actually, it reminds me of a story, Chris. I was the physician that at board meetings, and this is probably not a surprise at all, that occasionally would bring stuff up that was completely not on the agenda, to the point where the board actually started to embrace it. And one of the things that I would do routinely was to try and give a positive example of a patient win or a patient experience or a patient outcome. And I think it served many purposes over the years when I did that. And I think it was critically important for those individuals that were not clinicians in that boardroom to hear those things and to understand how the decisions they were making were impacting the end users, right?
Absolutely. And bringing those stories to life just causes people to think and feel and respond to it in a different way, whether those are people working towards change or those making those decisions that are perhaps creating the need for change. So Todd, I can't thank you enough for sharing such deeply personal experiences and wisdom and insight with us today. I think we're also grateful for your perspective. To our listeners, thank you for joining us as well. And be sure to join us for our next episode of Humanizing Healthcare. We will be talking with Michelle Brady, Patient Experience Officer at Mid-Michigan Health. It's sure to be another enlightening discussion. Thank you once again for being a part of our community, and have a great rest of your day.